Good afternoon. Appreciate everyone being here for our inaugural meeting of the Kentucky Health and Human Services Delivery System Task Force. And with that, we'll start with our roll call, please.
Senator Rocky Adams, Senator Funky Fromeyer, Senator Harper Angel, Senator Mays Bledsoe, Representative Heverin, Representative Mosier, Representative Neighbors,
Here.
Representative Stalker,
Present.
Co-Chair Meade, Co-Chair Meredith.
Present. We do have a quorum to conduct business, so we will proceed. First, let me thank everyone for your willingness to serve on this task force. This is the inaugural meeting, but in a sense it's not an inaugural meeting because of continuation in the work we did in 2022 with our task force for reorganization of health and family services. That task force was a result of Senate Concurrent Resolution 20, and the work for that committee resulted in Senate Bill 48, which we're going to cover in some detail today. So this is actually a continuation. And what we realized last year, almost to the inaugural meeting of the committee, was it was too big of an animal to take on in one interim session. This could be 2, 3, possibly 4-year task force when it's all said and done. And certainly we want to acknowledge that the Cabinet for Health and Family Services is our largest cabinet in state government with close to, I think it's 7,000 employees, and I think responsible for about $30 billion in funds that flow through the department. So again, it is a huge bureaucracy in itself. And I remind folks again that we didn't appoint this task force because we see anything wrong or that we're trying to be critical of anyone. We're just trying to provide the best service we possibly can to our constituents to improve efficiencies and effectiveness in each and every way that we can. And I want to personally thank Secretary Freelander for his willingness to cooperate with us in this. He was instrumental in our last task force session in providing information, providing these people to us, making them available to us, and the wealth of information they have provided. Unfortunately, you new members are not going to be privy to a lot of that information. What we tried to cover in the session last year was focus on the organization itself. And again, possibly we want to provide you with those organizational charts because it's a massive department that has grown over many, many years. We think that this session, this task force during the interim will focus more on operational issues. Again, trying to provide means to improve how the services are delivered within that particular cabinet. And with that, again, I want to thank each and every one for willing to participate. It's going to be like drinking from a fire hose a little bit, but just ask you to be patient with us. But with that, I'd ask you to take a look at the Organizational Task Force final report, which we provided to you. If you would, please turn towards the back. First part is a summary of the findings of the task force, but these pages aren't numbered. But if you go back to recommendations, I want to speak briefly to each one of those and how those were incorporated into Senate Bill 48. As you see, the first recommendation was that we continue the task force through interim 2023, which we have done by appointment of this task force. Second recommendation dealt with Child Support Enforcement Program, and we recognized there was quite a deficiency there in trying to collect those funds. So Senate Bill 48 calls for those functions to be moved to the Office of Attorney General with a very extended timeline. It won't happen until January of 2025 to give everyone plenty of time to prepare for this. We also took the Office for Children and Special Health Care Needs, put that service under the Department for Public Health, which certainly just made sense because that's where the majority of our physicians are employed and involved. So that was included in that bill. Recommendation 4 was to take the Family Resource Centers and Voluntary Services or Serve Kentucky and move those to the Education and Labor Cabinet through intensive lobbying and negotiation and discussion. That recommendation was not included in the final passage of Senate Bill 48, but it is something I think we need to take a look at once again. Because what we're attempting to do is align responsibilities with accountabilities And I think there's a good argument to be made that those could be better served through the Education and Labor Cabinet. But again, point for discussion later. The Office of Ombudsman Administrative Review and the Office of Inspector General. We had a lot of discussion about this during the last session after the bill had already been filed, and the final decision was made that we would not act on that at this point in time, so that'll be another point of discussion this year. Recommendation 6 was require Department for Medicaid Services and Department of Aging and Independent Living and DBH-DID to identify and eliminate redundancy barriers. That's a challenge that's gone to the Secretary to give us a report in December of this year. And require the Office of Human Resource Management to work with the Personnel Cabinet to identify systemic barriers and redundancies. I'll talk about this just a little bit. We have some problems with trying to getting people on board on a timely fashion, and we kind of have, Secretary for a better one of a better description, and almost like two personnel cabinets. We have the statewide, but then we have that function within the cabinet itself. And there is some redundancy there, so we're looking at how maybe we can eliminate that redundancy and get people hired quicker. The state guardianship program within the Department of Aging and Independent Living. We suggested that those should be in the jurisdiction of DCBS. And last but not least is that because of the growth of the Medicaid program and demand for public assistance, that we need to reevaluate the committee structure of our General Assembly, which we did. And quite truthfully, I think that's one of the most impactful recommendations that we made. As you folks know, before this bill was passed, we had a committee for Health and Family Services in the House and the Senate. We split that function. Now we have health services and we have family and children services. And part of the problem for our new members was that so much legislation has come to that committee because you would expect, since this is our biggest cabinet, this is also one of the biggest committees in terms of responsibilities. So we wanted to divide those functions out, and I think the success we saw in the last legislative session was indicative of the need for the split of that within our legislative bodies. It's worked very well. Quite candidly, I think that the issues of children and family services had a tendency to take a back seat to healthcare issues, and that's where we gave our primary focus, and that was not intentional, and that's just the nature of the beast. But now, since we've divided those issues, I think it's going to make us much more responsive to the issues that we face. With that, I know that was very brief, but are there any questions or discussions about any of those recommendations? If not, going on, we'll move on to the fourth agenda item. That's an update from the Cabinet for Health and Family Services.
Good afternoon.
Thank
I'm
you for
Eric
being here.
Friedlander, Secretary of the Cabinet for Health and Family Services. Is this the first meeting of the interim? I think it's close, isn't it?
I don't believe so. I think there were some last week.
Okay, all right.
Yeah.
I was hoping I was first.
You're still special to us.
Oh, thank you. So just a brief update on the implementation of Senate Bill 48, the reorg at the Cabinet. So what we've done is we've met with first Mr. Duke, General Counsel, and Mr. Maddox for Attorney General's office have met and talked. And we've had pretty good discussion. Obviously, there's, for lack of a better, but I'm just going to, my firm grasp of the obvious, with what will probably be within the Attorney General's office, a new Attorney General. They wanted to make sure that we had a transition book that was written with everything that will be in about the transition on child support enforcement and hearings coming out of the Ombudsman's office. So we had started talking with county attorneys a little bit, and they really wanted us to slow down. So we have, and it makes sense. And so we're going to coordinate with them as we move forward and talk about that transition. And so know that initial discussion has occurred. And that's pretty much where we are. And we've agreed that we will move forward in lockstep with them.
Secretary, let me interject just briefly, just to kind of bring the other members up to speed on this discussion.
Yes.
Was the County Attorney Association was very instrumental in getting this legislation finally passed. They actually did a study, I think it's back in 2015, about this particular issue, and had recommended that those functions go to the Attorney General's office, but they wanted to make sure that we did it in a very stepwise fashion. They were the ones that originally threw out the date of, I think I said January 1, but I believe it's July 1 of 2025. Mm-hmm. And the reason they asked for that extension was because that's when the contracts with county attorneys are written. So they also asked the Attorney General's office if they could put together a work group with them, which the Attorney General's office had agreed to. So we're trying to do this in very methodical, stepwise fashion. But thanks, sir.
Absolutely. And the number of employees, just the raw number of employees, is actually as big, if not bigger, than the current Attorney General's office. So it's a big deal. It's a big deal. It's a very complicated program around child support and collecting child support right now through the county attorney's office. So it's a complicated program and a big program, and so absolutely we need to take our time and make sure we do it right. Relative to, there was an Office of the Ombudsman recommendation that many of those functions move to the auditor's office. We've also had a sit down with folks from the auditor's office, including the deputy auditor, and also had a similar discussion, but more in depth, around the functions of the ombudsman's office, what in the bill we're talking about to transfer. It was, I guess it's not funny, but we were talking about all the programs at the cabinet, and one of the folks from the auditor's office said, "What's this about radiation?" And I'm like, "Well, you know, we do some regulation of radiation and radioactive materials as they come through, and as a part of the cabinet program, somebody could call into the ombudsman's office and have concerns." So I think that, to your earlier point, Chairman Meredith, the breadth of the work that's done in the cabinet, including public health, sometimes is surprising. So again, we sort of ended up in the same spot where we're going to make sure we have good transition documents written so that nothing gets lost in any transfer that may or may not occur. Beyond that, there have been numerous meetings between our Department for Public Health and the Office of Children with Special Healthcare Needs in terms of what that might look like. We're still not in complete agreement about what the budget, how we will display the budget in the next budget session, and then, but you'll see. We're working on what those details are. We're going to begin work on the personnel crosswalk that will. I think because some of that reorg language is interesting, we'll make sure that we present that reorg crosswalk for the Attorney General's office, for the auditor's office, and then internally within the cabinet. We have just had some very, very, even more initial than anything else I've described, between Department of Aging and Independent Living and our DCBS. I still think we'd love to have a conversation, but we started that discussion around what that would look like. But I'd say that's probably the least full conversation we've had, if I'm being straight. We have started some of the work and some of the other recommendations around some of the Medicaid pieces, and looking at what that might look like. And so hopefully I'll have a report for you in December, and we can go through some of that when we get to the legislative piece of this later on in the agenda, and I'm happy to take any questions.
Any questions? Yes.
Representative Sarah Stocker, Jefferson County, District 34. Clarifying question, when you talked about child support payments being moved over to the Attorney General's office, is that do those payments only include payments from one biological parent to another, or does that also include payments that biological parents might be, this is the assumption I'm under, that biological parents, if they have lost custody of their children and they are in foster care, out of home care placement, that they are being billed while their child is out of the home and is needing to pay the state back as part of their plan to get their child back. Does that make sense? Like, you have to work your plan, but it's my impression that there's also families that are being billed for that care that the state is then taking on, and that sometimes that creates an issue with children being able to be reunified with their families if the families have yet to pay that, or maybe were unaware of it the whole time. So I didn't know if that was also pulled into these child support payments. And if you don't know, and I don't know, it's okay.
If I start going down a wrong road, Lisa Dennis is going to come up here and correct me,
Okay.
which is why I have everybody here. So this is a relatively complex piece because it is a federal piece. So court-ordered child support, if somebody gets in arrears or any kind of payment for children, right? So some of that comes to us. The cabinet's responsible for trying to figure out how to establish paternity, how to keep up and sometimes transfer those payments from non-custodial parent to custodial parent. So yes, all of that occurs. Oftentimes people get in arrears, particularly relative to the population served through child support enforcement. And that can cause all sorts of challenges, particularly people as they re-enter from, if they happen to be incarcerated, it might be why they were incarcerated. There are lots of levels of complexity to this. Our collections are behind. And so the challenges of performance of different county attorney's offices, all of this comes to play. And so it's a longer answer, but that's the gist of the program. And if I have missed in any way, Lisa, you can help me out. Okay, good. Hey, what do you know?
Just a brief comment about that. We've made much ado about the fact that we're $1.4 billion in arrears. I'd just like to caution our task force members, just bear in mind that's a number. What we're looking at is to improve upon that. We think there's opportunity. How much we can improve, I don't think anyone can speculate. But we have 120 counties, and each one has different situations, and the ability to protect or to collect these payments are different in Jefferson County than they are Estill County, Kentucky. So it's a challenge, but we think by moving it to Attorney General's office will be better communication between the Attorney General and the local county attorneys, and possibly what we've seen in the past. So it's a stab at just trying to make a situation better, but appreciate that.
Exactly.
Any other questions, comments? Representative Meade, Co-Chair Meade.
Thank you, Mr. Chairman, and thank you, Secretary, for being here today. Appreciate all the work that you do and your communications with us. Just a couple quick questions. With that transition to the Attorney General's office with the child support, I know that initially there was some plans on making some changes to the current system. Since this change is taking place and this move is taking place, have those changes been put on hold until that gets moved over there?
The system is what's called a green screen system. It is a DOS-based system. We basically have to go to retirement communities to find programmers, and I'm a little funny, but I'm not really funny. It is the back end of the old unemployment system, so we feel like we have to move forward. Any system that will move move from that green screen DOS-based system into just something that is more modern. And so I don't think we'll do anything that would make it any more. Actually, I think what it'll do is make it easier for the Attorney General's office to take it over. It's expensive being on the mainframe from a COT perspective, and so I really think if there's data transition and migration issues, it might be good for us to try to deal with them. So we are still trying to move forward. We think it's the right decision, and we think it'll actually be helpful for transition so that somebody doesn't have to try to transition and data migrate all at the same time from a system that nobody knows how to write code for anymore.
And then you mentioned COT. So is it the plan that the current staff, IT staff, is it going to transition to the Attorney General's office, or will that be within COT?
That most of that staff's in COT.
Okay. And then I guess I've got one last question. So how are you planning for the impact of existing MOUs with business partners during that transition?
That's an excellent question. I think it's one that it's a bridge we'll cross when we get to it. But I think all of those MOUs should transfer, particularly if we're clear about what they are. And that's what we're hoping to do.
Okay, thank you.
Any other questions, comments? If not, Secretary, please feel free to proceed. Next agenda item.
All right, I'm bringing it back up.
Thank you.
Carrie Banahan, Deputy Secretary of the Cabinet.
Lisa Lee, Commissioner, Department for Medicaid Services.
So this next presentation is really about the impact of the end of the public health emergency. We'll go through some slides. There's already one that's changed, but we'll explain that as we go and some of the challenges we're seeing as we move forward. So let's begin. The first is just sort of a representation of Medicaid enrollment over the years. You can look at, really, this is basically over the public health emergency. You can see a pretty big dip around June and July of 21, isn't that right? Okay. And it's when we really stopped the major presumptive eligibility piece. And so you'll see what happened there was we rolled presumptive eligibility folks off primarily. So the ones that we had signed up, we rolled them all off. And since then, I think we've got about 500. We had gone up to like 120,000 during the teeth of the pandemic. And then we backed that off really where we really felt we were coming out. And so what you see there is really sort of just the hospital presumptive eligibility and nursing facility presumptive eligibility, and that's why the number's so low. This is caseload distribution, and Lisa, I'm going to let you talk a little bit about this, but you see these caseload distribution counts. You're going to see in that May number, that's one number. Your slide's got another number. My slide has another number. These numbers are all, if I can say, just fluid. These are projections as we run our systems. So know that what I'm going to talk about today is today's number. That's probably going to change as it goes forward. But I just wanted to let you know, you'll see they're all within range, but they're all a little bit different, and that's just kind of how this process is going to work. So I want to say that up front, and you'll see as we move forward. Lisa?
So typically, during traditional Medicaid operations, individuals have to renew their eligibility every year. They have to do a recertification packet. During the public health emergency, in order for us to receive that additional 6.2% increase in our funding, we could not disenroll anyone from the Medicaid program. Beginning in April, we started renewing individuals, that annual recertification period. So we took all of our cases, and we have 12 months now to get individuals recertified in that year period. So we have taken all of our cases, and because we had not recertified individuals during the past 3 years, our caseload for our eligibility workers have increased by about 20%. So the caseload distribution count that you see on this slide represent about a 20% increase in workload for our workers. And as we go forward, as we get to the end of the public health emergency and cases are recertified, those caseloads will be going down.
So typically Medicaid recertifies folks on an annual basis. We had several years where we didn't. So we now have caseworkers in DCBS who've never done a Medicaid recertification. And so this is when Lisa says it's a 20% increase, it really is over what they've been doing around SNAP and child care and TANF, all of those similar kinds of programs. So this just gives you an idea of the number per month. We're essentially re-enrolling a big piece of Medicaid. Okay. This is the one, right? Mm-hmm. All right. And you all have a copy of the new slide? Hopefully. Good, thank you. So in the end, it was about 74,000 renewals. And we really, the number of folks who were reapproved for Medicaid, right? And that's those who have applied, gone through the entire RFI process, got their information in, or we were able to do some passive enrollment, is really about 50%. So of that, well, a little more than that, but of that 74,000, we've had about 43,000 approved for Medicaid. So we were expecting that to be higher. I'll just be frank. We thought that was going to be a higher number. It just hasn't been. And so we think about 34,000 at this point in time are going to be terminated, but there's another about 6,000 that are eligible for a qualified health plan on the exchange. We don't have the number of that group that is signed up. You'll see we shifted that data. I thought it was more clear on this slide to show you how many folks actually have not re-enrolled or are not eligible to be enrolled in Medicaid. And that's that 34,000 number. That's about 46%. So I want to be clear, they're eligible for other health care, but they may or may not sign up for that health care. They know they're eligible. We get them with a connector or an agent to be able to sign up, but it's not Medicaid. There's going to be a cost in many cases. So we don't know that number yet. That's one of the numbers that's going to change basically every day, particularly if we are able to figure out how many of these folks actually signed up for a qualified health plan. You'll see we have if you combine a couple of the numbers, about 110 folks who we still have to process, but that was as of last Friday. That number has probably changed. There are about another 2,600 where we have RFIs out, meaning they sent something in and we needed more information, so we sent it out. That's a number that's going to change as well. So we'll see what that is. And then in all of this, we anticipate that some of the folks that didn't return their RFIs, even though requests for information, even though we really did try to front load those we thought might not be eligible, we're probably going to have to give you a couple of months before we have a really at least better handle on it. But we have these preliminary numbers. Please take them as preliminary because they changed from this morning, to be frank with you. So these are just, this is going to be close, right? This is not far off. So when you look at these numbers, we're going to be in this kind of range for this first month, give or take a few percentage points. But I just wanted you to know where we are. But I think once we end this month, you're going to see that we'll be a few percentage points here and there, but we'll be really close to this. And then what will happen, and what I'm afraid is going to happen, is some of those folks who dropped off are going to go to the pharmacist. They're going to go see their doctor. They're going to find out they don't have coverage, and they're going to re-sign up. And we saw this with SNAP when we started doing recertification. What happens is folks will drop off, then they'll come back on. And unfortunately, these first several months, and we've tried to be really clear about how we communicate, the managed care organizations are reaching out, the hospitals are reaching out, we're reaching out. We've had the experience of reaching out to folks who said, stop calling me. Too many people are calling me about signing up. I know I need to sign up. So I know we've reached people, but it's like everything else. The reason we have about 110 is everybody kind of that last week started to give us information, and so kind of swamped us a little bit, just to be frank. But we've really, to have just 100 out of, thousands and thousands and thousands that we're working on, it's not great, but we're learning as we go, and we are. That's what, and we'll tell you what we're learning as we go. We're going to see who signs up for qualified health plans. We're going to see if we can figure out private coverage. We're gonna try to figure out where we are in terms of signing folks up. But it's a huge task. It's one I think I've told several of you. It's one of the things that makes me lose sleep at night. I have about 4 of them in the cabinet, but this is one, because this is a huge undertaking for every state in the country, and you've heard every state in the country going through this. But you need to know where we stand in Kentucky.
The Secretary touched on this just a little bit. On the previous slide, we talked about passive and active renewals. Passive renewals simply means that we have enough information in our system, or we have enough data sources that we can determine an individual remains eligible, and that individual does not have to take any action. Active renewals means an individual does have to take action. So when we send out our notices, either our request for information or our complete renewal packets for those individuals who have to take action, if they don't take action, we monitor. We look, for example, if someone starts an application or logs on to our Connect system. That's our eligibility and enrollment system. If they log on to Connect to start an application or to try to upload their information, they don't complete that process, we give them a little nudge. A nudge is just something to say, hey, you started this application, but you didn't finish it. You want to go ahead and finish it. We also have sent out alert messages just saying, hey, it's time for you to renew. We have made 791 alert calls, and you can see the almost 17,000 nudges that we have completed. So we have just the number of applications that we have sent out, the renewal notices. This is just to engage our members to make sure that they respond to us. And one of the other reasons that we do this is it is a federal requirement for our individuals that we have to reach out to them in various modalities in order to contact them and make sure that they understand that they have to take action in order to remain enrolled in Medicaid.
And you all know you don't often hear me being complimentary of our MCOs, but in this case, they have really been aggressive about reaching out, working with their providers to try to get folks signed up, and it's been a challenge.
So during the public health emergency, we had several flexibilities. Some of them pertain to providers, some of them pertain to members. And as we go through this unwinding period, we have to go back, revert to the way that we conducted business prior to the public health emergency. However, there were some flexibilities that we implemented that we thought were very beneficial to either the member or the provider, and some of those flexibilities will remain. And we've just given a few little examples here. We do have the Kentucky PHE Flexibility Tracker that individuals can go on and look and see exactly a full list of all the flexibilities that we implemented. But in May, beginning May 11th of last month, we did suspend provider revalidations. Typically, a provider enrolled in the Medicaid program has to revalidate their information no less than every 5 years or so. So during the public health emergency, we did suspend those. Those provider revalidations will now have to be completed. We are no longer using unlicensed facility as alternative locations. Of course, that was a flexibility that early on in the public health emergency, we thought we may need some facilities to accommodate overflow of individuals in case we had a huge increase or a huge surge in COVID individuals who needed to be treated. We did give hospitals a 20% add-on for their diagnosis-related grouper code. That's just 20% add-on to their payments for any patient that was COVID-19 positive or had a diagnosis. That also went away May 11th. Our nursing facility, $270 per diem add-on, also for COVID positive patients. That ended on May 11th. And the second presumptive eligibility period in a calendar year also ended. Some things that we're extending is long-term care resource disregard. During the public health emergency, we disregarded some resources for individuals who are in long-term care facilities to help facilitate their application. We do go back and recheck those resources later, but we make sure that individuals who are in long-term care facilities can get their eligibility determined. We also are implementing our 90-day period for individuals to file an appeal and for the state to make a decision. Prior to the public health emergency, that was 60 days. telehealth audio only. We are keeping that in place. However, non-HIPAA platforms have been extended only through August. What this means is when individuals participate in telehealth during the COVID emergency, providers could use such platforms as Zoom and FaceTime. Those platforms are not HIPAA compliant, and any HIPAA compliant platform for the use of telehealth will be terminated on August the 9th of 23. Typically, if an individual disenrolls or exits the Medicaid program, when they re-enroll, we will assign them to a new managed care organization if they do not choose one. We will now allow 120 days for them to re-enroll. We will automatically re-enroll them in the last managed care organization they were in when they exited the program. Some permanently implemented flexibilities include our nurses' aid application. Instead of using a Social Security number or requiring a Social Security number, we will use their I-9, and expansions of telehealth outlined in our regulation that has been recently updated. So during the public health emergency, the department, as all state Medicaid agencies, received an enhanced federal match. We call this our FMAP. So we received that during the public health emergency. As part of the unwinding, Medicaid directors were very concerned that elimination of the public health emergency or termination of the public health emergency would result in a huge fiscal impact if that federal match just completely went away on the day that the public health emergency ended. There are lots of conversations with their National Association of Medicaid Directors and others with federal officials. And during the unwinding period, during the rules, they have allowed states to phase down that FMAP rather than taking it away completely. So this just tells you how we will be transitioning that FMAP phase down. We do have some criteria that we have to abide by in order to get that enhanced FMAP through December 31st of 2023, which is we cannot have any eligibility guidelines that are more stringent than were in place before the public health emergency. We have to make sure that we help individuals update their contact information, and we cannot enroll anyone who did not return their mail without first making a good faith effort to contact them using more than one modality, for example, text, email, phone call.
It's a big fiscal deal, is the way that I will say that. Every percent is a tremendous amount of funding for Medicaid, and as you'll see, both with that, we'll get this up on our website too. We're going to be as transparent with this as we possibly can.
And again, we have our website. It's medicaid.unwinding.ky.gov. It has lots of information about our unwinding activities, numbers, and FAQs, frequently asked questions, if anyone is interested.
That's it.
I think that's it.
So any questions about Medicaid?
Allow me to start, if I could. You've done an excellent job as always, but I'm trying to figure out what Medicaid looks like in the future. You know, my first session was 2017. At that time, we had 1.3 million Kentuckians on Medicaid. Budget was $10 billion, and I said then, so I think it's as large as it ever should be. Because if we're getting people back to gainful employment and we're improving the health of our population, the funding needs to be sufficient. But now we're 1.7 million on Medicaid, and the budget is 15 billion. And I know it's still early in our projection, but 2024 will be here before we know it with the budget. Do you have any speculation whatsoever as to what that number will look like for the next biennial period?
I think it's really hard for us to project right now. I'm not trying to be evasive. The number that we had this month really is surprising to me. So I think it's going to take time for us to realize that, because the number of folks on Medicaid and what that FMAP, those impacts go like this. Mm-hmm. And so we're really struggling with figuring out how to give you an accurate projection. It is, we just, if we gave you one before this month, it would have said probably one thing. If we gave you one after this month and just based on this month, it would be another thing completely. I don't know. We just don't know at this point.
And that's fair. I don't mean to put you on the spot.
No,
I'm just trying to figure out, where we're going. You would think with supposedly the largest economic expansion we've seen in this state's history, we would see more people within the private sector getting their insurance. And that's not coming to fruition at this point in time. And is the issue is that these are jobs that aren't providing health care benefits, or are we not getting people back to work as we anticipated, or is healthcare just so expensive that people have no other alternative at this point in time?
I don't know, but it's like I say, these numbers are surprising, and so I'm asking the same questions you just asked me. Who on this transition to private health insurance, and how can we figure that out, or can we figure it out? How many folks who are eligible for the qualified health plan have actually gone on ahead and signed up? Or are they waiting to find out that they don't have any and that this is their only option? I think we're going to see some of that. I can't tell you how much. Most people on Medicaid, most of the folks on the expansion piece of Medicaid have jobs that are not paying them enough, right, in order for them not to receive Medicaid, or they have a number of children that makes them eligible, and certainly can show you those numbers. I think we've talked about it before. So there's that piece as well. And then in terms of increased spending by Medicaid, there are places where we have, I think, done a great job, which is in the hospital outpatient program and hospital inpatient program, paying average commercial rate. The hospital's paying the difference in the general fund cost. But that's been a chunky expansion. I think once we add outpatient and inpatient together, for a full year, I'll bet we get over $2 billion flowing to our hospitals, which keeps the small ones open and the rural ones open, and particularly outpatient's going to make that, the outpatient A-trip is going to make a big difference there. So as we have discussed, if somebody, and I've talked to other provider groups about this, if folks want to provide us the general fund match so it doesn't hit the general fund and the taxpayer, right, let's figure out how to do that. Also within, I guess it was my first session back, was was it Senate Bill 50, the single PBM. We've seen some savings from that. So we don't know. Sorry, it's a long way to get to we don't know. But it is, these are all the factors that are at play.
That's
I
all right.
don't know
We're
if
going to
that
have
was
continued
helpful at all.
discussions on this. I know
Yeah.
with the budget review coming up that you folks will be testifying numerous times. We may not have this opportunity to go into details we did in the past because we don't have Medicaid oversight any longer. We may have to do it within Health Services Committee meeting. But I just wonder, are there any goals, and is there a reasonable goal as to where we should be in terms of the health of our population? We talked in nauseum about we were 47th forever. Now we're, I think, around 44. That's still nothing to brag about. I think that's a direct result of people having access to insurance that they haven't had before, but we're really not moving that needle a whole lot. And additionally, getting people off of Medicaid into gainful employment. Do we have any targets for that? Because taking sick people is not a good economic model.
Right.
It may create jobs, but there's a cost associated with that. So again, I think to sustain the program in the future, we have to improve the health of our population. And secondly, we've got to get our population off of Medicaid. Right now it's 40%. Right. So do we have any targets to address both those issues? Where would we like to be?
The two pieces I'll talk about, and Commissioner Lee, you can chime in. One of the things that is also excited about that A-trip piece, right? Sorry to abbreviate. The additional payments to hospitals, is there's a quality piece to that. And I talked with the Hospital Association. They are excited about how quality is working. I really want to, well, before now, but I think it would be wise to bring folks together, FQHCs, I'll put this to you all, FQHCs, hospitals, MCOs together, who should have the same goals of getting people healthier. And now we have funded, right, in hospitals, and there's certainly more funding that can be done, but within the hospital structure, a quality piece that I hope moves us forward. I think in terms of Medicaid enrollment numbers, we're going to see what unwind does to